The first question is, what is a recommendation for genetic testing? Aman, I think this question for you.
As of now, I would not recommend genetic testing as a standard of care. These genetic testing platforms are quite expensive. Commercial labs can cost up to $4,000 or $5,000 for Foundation 1 caries. I think this provides valuable information to the net centers who are researching these diseases. And if you happen to be near one of those net centers where it's been done under research protocol without really costing the patient, please go for it. We do it, Memorial Sloan Kettering does it. I don't know if Moffitt does it. So I would recommend to get it done under those circumstances. But out of those, I would hate to recommend that in my patient or a patient getting stuck with a big bill where clearly right now it's not ready for prime time. We are still using this information to learn more.
There are a few questions regarding to the liver. I bet, Michelle, this is for you before your procedure. How do you test or evaluate your liver reserve?
Thank you for the question. It's very simple. We just ask for to have a liver panel tests. So we like to see liver synthesis, liver enzymes, ALT, AST. Understand the INR, right? To see synthesis, to see albumin, total bilirubin levels. So it's a global understanding of the patient function. There's not a single item that we look for. In most of the cases, we like to look at the patient, examine the patient at the same time, put together the data with the enzymes. If we are going to perform radioembolization, that's a different story. For radioembolization, the patient's total bilirubin level cannot be higher than 2. So if somebody has bilirubin of 2.5 and is coming for us for a Y90, I'm not going to use Y90. I definitely can do chemoembolization or a blend embolization or ablation in those cases, but not Y90. Same thing is true if there's a trending going up. Patient's liver function is not doing well. For example, I started with a bilirubin of 0.9. 15 days later was 1.4. 15 days later was 1.8. Even if it's below 2, there's a trend going up. So we are going to back off from that case, give some more time for the patient to make sure that it's not getting worse and worse. And then if it's stable below 2, we'll proceed.
The other question is also for you. One of the audience like to know the volume you've been addressed on the neuroendocrine tumor at your particular center.
The volume?
Yeah, the volume, the number of patients you guys have been treating.
Oh, honestly, I don't know the answer to that. I do know that we treat hundreds of patients with liver-directed therapy per year. What's the percentage of those? I don't know what's the neuroendocrine tumors percentage, to be honest with you. We feel very comfortable treating any patients that need the liver-directed therapy. I think that's my answer. Somebody was asking me before if we treat other liver cancers. Yes, primary cancer, cholangiocarcinoma, HCC, and also other metastatic disease like colon cancer, breast cancer. So yes, we will be happy to consider helping any way we can. We feel very comfortable doing those therapies.
What does NSE stand for your routine blood work?
NSC is one of the blood biomarkers called neuron-specific enolase. It's usually expressed more in high-grade neuroendocrine carcinomas, and I use it as a marker to response in treatment for high-grade neuroendocrine carcinoma. I would not advise it to be checked for your typical carcinoids or low-grade neuroendocrine tumors, usually not positive in low-grade tumors.
And by the way, the higher the number of this marker, the worse is the prognosis.
And usually also this is one part of the spectrum. So you don't look at one number and try to jump to a conclusion. So usually we look at all different tumor markers at the same time. We just don't just get too excited about one particular number. And there's a few questions regarding PRRT. The one question is, what will prevent a patient from getting a PRRT, and how often you should get a delta scan?
Let's do the easy one first. What would prevent a patient from receiving PRRT? PRRT, although fairly safe in terms of short and long-term safety profile, but has definite risk for nephrotoxicity or injury to kidney. And that's why when we do give PRRT, we give amino acid infusion for 4 hours to protect kidneys from the radiation toxicity. So somebody with compromised kidney function are not going to be an ideal PRRT candidate. Again, for any systemic therapy, we do need a fairly normal liver function test. So that's also kind of important. Besides that, one of the concerns I personally have with any radiation-based therapy, systemic radiation-based therapy, is long-term exposure to radiation and bone marrow toxicity. So far, what we know from NETTER-1 clinical trial, and it's safe, but in Europe, where PRRT has been in use for like good 15 years now, there are some publications which suggest that it does increase your risk for myelodysplastic syndrome and certain leukemias down the road. So we have to be careful using PRRT, and also limiting exposure to other agents which are myelotoxic, like temozolomide. And in the same breath, I think I personally am getting more cautious about using radiation-based therapies, although it's not an absolute contraindication that you cannot do Y90 or SIR spheres in liver, but just with this systemic therapy option, the PRRT, we have to now reevaluate, should I be more favor for TACE or chemoembo or bland embo versus Y90. We don't have the data yet, but we are definitely cognizant of that fact.
Let me make a comment on that. I just like to tag to what you said. In our algorithm, as I said before, we tend to do Y90 first. However, if we are concerned about the liver function, and the patient has a borderline liver function, or the patient is showing there is, let's say, has been resected already, has a small liver reserve. What is a small liver reserve, a lower liver reserve? Somebody who has, instead of having the normal large liver, has been resected already, has gone through chemotherapy, has some changes in liver enzymes. I tend to not do Y90 for those cases. Why? Especially if it's multicentric disease in the liver, multiple nodules. We need to go in and inject radiation to the whole nodule. We do see atrophy of the liver after Y90. So we have to be mindful about that. So I hope I didn't make the things more complicated. I hope it helped. But I agree with your comment. I think in those situations, in that scenario, we prefer to do blend embolization, which actually preserves a lot of liver function, does not cause the same damage or atrophy.
And the other thing we keep stressing is the multidisciplinary approach is very important, and every single patient are different. So some of the patients, very limited, small amount of disease, may be healthy enough and low grade, maybe surgery will be very easy, quick answer. On the other hand, if that patient you send for PRRT, I think it's overkill because, may not be effective and you have a systemic effect down the road, may suppress your bone marrow, get the leukemia down the road. On the other hand, if you have disease all over your place, all over your body, your bones involved, your liver's involved, and maybe PRRT will be a very good thing to do because you treat the whole systemic system all at once. On the other hand, if someone with some disease, localize the liver most, maybe interventional radiology, do a liver-direct therapy will be much more effective. As a matter of fact, currently there's some thinking about to do a liver-directed PRRT, just use PRRT agent, only go to liver only. So just a lot of things we are still learning in the whole process. Here's another question: a patient with initial diagnosis of duodenal primary with liver metastasis. They said that they cannot do anything about the liver tumor. Or PRRT good choice to treat primary tumor in the duodenum?
So patient is clearly not a surgical candidate. That's how it sounds like.
Based on the question, they say that evaluating physician consider that's not a good candidate. Maybe they find the wrong surgeon.
Yeah, that was my follow-up point, that maybe they need to go see Dr. Wang. But and that's a difficult question. So the problem with the systemic therapy for neuroendocrine tumor, they're a really good agent in stabilizing the disease and long-term outcome. But at the very best, the radiological response or the times we would be able to shrink the tumor is 18 to 20%. So if somebody needs to use PRRT with the sole purpose of debulking the tumor in the primary site, that probably is not the best option unless that's our only option. Somebody's obstructing or gonna get obstructed and they cannot get surgery for some reason, that's our probably best systemic therapy with the highest response rate of 18%. Afinitor, the response rates are 7%. Somatostatin analog for response rate 0%. It's a cytostatic agent. Doesn't let tumor grow, but doesn't shrink it either. So I would suggest a second opinion by another surgeon and see maybe they can take up a case and review. Worst case scenario, yes, PRRT can be done for those situations. I worry about if we are reaching to a point where there's an impending obstruction, it can complicate matters because what if we give PRRT, patient's radioactive for a few weeks, and what if the patient gets obstructed? Then it's a radiation hazard for everybody now, so the surgeons who operates, etc. So I think this is a complex situation, needs to be evaluated in a multidisciplinary center, in a net center. That's what I would suggest.
Yeah, one other concern I have for the PRRT using for the GI tract itself is sometimes if the tumor response has scarred down, now you have a stenosis or narrowing of your intestinal tract, that may be a problem itself down the road too. So you have to take that into account. Now, another question for you is how often can we do an embolization of the liver?
Let me divide this answer in two. If you're doing Y90, typically we like to give at least 9 to 12 months interval. So if there's no indication for a chemo, for blend embo, for example, today, 9 months later, we can reevaluate. For blend embolization, because there's no chemotherapy involved, you can do as frequent as necessary, meaning the minimum we do is 2-3 weeks apart, and on average, do 4 weeks apart. Basically, what we want to make sure is that the liver and the patient can recover from that insult, from the embolization. Make sure we see the patients in clinic in 2 weeks later, after the first session of blend embo. Make sure the liver enzymes are better. Make sure the patient is strong. Make sure there's still residual disease, very important. And then we'll perform a second intervention. But yes, it can be done as frequent as 2 weeks apart or 4 weeks apart.
Can Y90 be done for any other organ other than the liver?
For other than the liver, correct? No. Y90 today has been explored for other things, but for cancer itself, it's just focused on the liver. No other organs, no. Ablation, though, can be done in multiple organs. Ablation can be done in the kidney, can be done in the lungs, can be done in the kidney, can be done in the adrenal gland, can be done in the bones. Of course, we need to understand, I'm not saying we need to do ablation everywhere in the body, right? If the patient has, like somebody was asking me before, patient has a history of a single lesion in the liver, we can do ablation, no question. Patient has a single lesion in the lung or 2 lesions in the lung. There's a data now from Europe, actually not for neuroendocrine, but for other cancers that up to 3 lesions in the lung, they're approved now. It's part of the guidelines in Europe to do ablation. if the lesions are small, especially if they are peripheral. So it depends on the context, right? Again, I agree with Dr. Wang, every patient is different, but it should be considered if the patient has oligometastatic disease, meaning very small amount of tumor, right?
Another question is also for you. Do you have any standing protocol of when you're applying all this technology to your patients?
Yes, we do have a standard protocol that I tried to summarize. On the other hand, we try to tailor, going back to the precision medicine here, we like to tailor also to patients who come directly to us. I'll give you a concrete example. We had a patient with a mat of 15 centimeters. 15. This patient came to us and said, look, I already purchased my coffin, I chose my flowers, my music, etc. I'm done. I know I'm going to be done. But I heard you guys might be able to help. And now, this is 2013, 5 years later, she's alive. So if I was going to follow the guidelines, the algorithms of the societies, etc., that patient would be prescribed chemotherapy, sent to my friend here, and that's it. Whatever survival that patient could have. No, we try to tailor the best care. And we did not do Y90 because I thought it was too much, too big. We actually did 4 sessions of blend embolization. The tumor was 15 shrunk to 7. And because it was peripheral, we were able to burn it and it's totally gone 5 years later. So who would say that, right? So we'd follow algorithm, yes, but we also think in the big picture and try to tailor the best we can for that particular patient. Always with a multidisciplinary approach. That's important to be told.
How soon do you expecting to see positive result with Afinitor treatment, and how often you scan those patients when you put them on Afinitor?
In my experience, Afinitor always works. I've yet to see a patient who fails Afinitor outright. The question is, how long would it work, which nobody knows. From clinical trials, we know that most patients will at least benefit for about a year, 11 months. Some patients go on it longer. Some patients progress on it in a matter of 6 months. If I start somebody on Afinitor, I like to do my first scan in the 3 months later, give Afinitor at least 3 months in for it to kind of start working and go from there. I also want to kind of mention regarding Afinitor, we are of late been using systemic therapy with our local regional therapy, which I think works amazingly well. I'm a big proponent for local regional therapy, especially the entire bulk of burden of disease is in liver, and try to expose them less to the systemic agent. But lately we've been trying to incorporate Afinitor with our local regional therapies, TACE and bland embolization, and we've had some fantastic results. We just submitted our long-term follow-up data to ASCO, and hopefully next meeting I'll be able to kind of tell you about our hepatic progression-free results with that combination technique. Usually when we do embolization, we hold the systemic agent for good few weeks before and few weeks after. But what we found from our mouse models and now from our clinical data, if you continue the systemic agent, you actually have a double whammy on the cancer. You're giving the anoxic or injury to the tumor from within, and the cell surface, which he actually nicely showed one of the ring-enhancing lesions, the alive tumors, we are able to target that with the systemic therapy without holding treatment. So the data looks pretty exciting. It still needs to be validated in other subsets.
Another question for you: what's the difference between lanreotide and octreotide?
In my mind, they're both same. They work in the same way. I think it's just the patient preference and the physician's preference. They both have somebody who understands the pathophysiology, why they work. It's the same drug. or same type of drug. It's the route of administration somewhat different. One drug needs to be mixed, other comes in the mixed pre-filled syringes, etc. So based on the nurse who's administering it, what she's more comfortable with, it's more logistical rather than mechanistic. So I would not favor one over other. I think in my mind they're kind of same.
One other interesting question is how you get information and education to non-NET specialists. I guess tell them to come to the conference like this. The other question is...
I do want to mention that within my short span, like 3, 4, 5 years of career, I've seen an exponential growth in interest in neuroendocrine tumors. So I go to the NET-specific meeting and GI cancer-specific meeting all the time. And let me tell you, 3 years back, there was no neuroendocrine-specific study group in ASCO. When we submitted our research study, we had to submit it under GI cancers. Now we have a specific NET-specific, and every year we see tons of new data, abstracts, and posters being presented for NETs. NANETs, our National Neuroendocrine Tumor Society meeting, last year was sold out.
And
that's been happening for 2 consecutive years, which is a great sign. And these are not just neuroendocrine experts who are attending these are community oncologists. So I think there's been a growing interest, and we are on the right path in terms of educating our colleagues.
Is neuroendocrine tumor hereditary? I'm answering that question. Just one doctor in the NIH, Dr. Wank, W-A-N-K, not W-A-N-G, he believed this is a genetic disease, and he been devoted his lifetime studying this. But I was making fun of him. I say, how many patients you have? And last time I talked to him, he was about 32, and 32, 4 of them are from mine. Referral. So I say, if this is genetic, you should be see, 20,000 or something. So to answer the question short, there's only one thing we can say for sure. If you have MEN1 disease with a lung neuroendocrine tumor, maybe there's some percentage, like 7%, some article quote, maybe genetic related. And that's the only thing I can remember is genetic related. Otherwise, we usually don't recommend have the whole family worry about the condition. Is it genetic and going to transmit it to the next generation? So you can have kids. Don't worry about it. The next question is genetics is always, and nutrition is always important in the network, yes. And we always, all the institutions have a nutritionist on board. Someone asked a question about side effect of afinitor, somatostatin, PRT. I think that question will take 3 hours to answer, so I'm going to avoid it. Does Zomero have any effect on the development of carcinoid heart disease?
It's a very good question, actually. We are trying to study this, and we recently met with the industry partners, and I think we are kind of nudging them to study this. I have an anecdotal case where the patient had carcinoid heart disease from elevated serotonin. So some of you all who don't know, if you have super high level of serotonin, it literally eats up the heart valve on the right side of the heart, and you develop right-sided heart failure. So it's critical to lower the serotonin levels as fast as possible, either with embolization, chemotherapy, surgery. You need to debulk these tumors, either chemically or surgically, to lower this serotonin level while we cover them with somatostatin analog. Having said that, I think Zermelo mechanistically reduces the production of serotonin, so I think this should help. The caveat is that the Telestar study was designed to study diarrheal effects, so the label is for, FDA approval is for diarrhea control. But if I have a patient with carcinoid heart disease, and I'm optimizing it maximally with my medical and surgical interventional radiology techniques and they're still having elevated serotonin, I would not shy away from using it to control the serotonin level, because once the carcinoid heart disease develops, it's not reversible. And that's one complication I would like to jump sooner than later. And it's life-limiting. So I'd like to be aggressive. And yes, I would not shy away from using in case-by-case basis in those scenarios.
Yeah, there's also other potential usage, and I will address that later this afternoon. Do you recommend patients on the vegetarian diet for New England patients?
I'm myself a vegetarian, so I might have a bias. To be honest, there is no data suggesting either way. I advocate a well-balanced diet, low in refined, processed sugars and carbs. And that holds true for not just for the cancer standpoint, but cardiovascular health and metabolic syndrome, etc. So, but going absolutely vegan or vegetarian, I wish we had data to suggest that. And these studies, the causation studies with the diet, needs thousands and thousands of patients, which unfortunately is very difficult to study in a rare disease. So I don't think we'll ever have that data, unfortunately. Just eat healthy, well-balanced diet, avoid sodas and carbs and refined processed foods.
Yeah, and my personal experience, whatever diet you want beyond just be balanced, make sure you have enough nutrition on board. If you don't try it on vegetarian diet, make sure you have enough protein, all those kind of things. Because if you don't have enough protein, your wound healing process is going to be a problem. When you go into surgery, your wound may not heal too well. So that's from surgeon's perspective. Why is this important to identify primary before you consider liver embolization?
I want to say, I think things can be done simultaneously, right? If somebody is very symptomatic and we see disease in the liver while we are investigating, and typically some patients, I would say most patients that we see, they have evidence where the disease is up front. But some patients don't. And for example, sometimes the patient has, as I said before, it has a small bowel tumor that we cannot see where it is. It's so small. So regardless of the sequence of things, I think what is important for me as a physician taking care of that patient is to make sure that I can do everything that I can for the primary to be identified and to be resected. That's the way that I think that we can guarantee long-term great results and not focus only in the liver. I could be very focused in the liver only, which is what I do, and forget the big picture. We need to focus on the big picture to guarantee better outcomes.
I'm going to try to bring him to that house to work with me.
Or I can bring you to Charleston, maybe.
This other question is, pathology report always including the type of somatostatin receptor. In other words, to identify the type of receptor. Is that really important? And can that be done of the tumor receptor typing 1 month after the biopsy? What's the utility of using the receptor status? Is that useful?
We do not routinely report the type of receptors on a biopsy. As of now, it's not needed either. It's done in some institute for research purposes where they have particular stains to stain particular type of somatostatin receptor 1, 2, 3, 4. However, we have the gallium dotatate scan, which basically picks up the somatostatin receptor, and that's more practical reason why way to detect somatostatin receptor, because it also has therapeutic implication in terms of role of PRRT or not. So yes, somatostatin receptor is not needed on a biopsy, and we get a pretty good idea about somatostatin receptor positivity based on gallium scan, 90% sensitive.
For the course of time, I'm going to answer this question very briefly. So one question is observation versus active treatment. I think the observation stands for wait and worry, so we don't really recommend that, do something. And the second thing is it possible to have a carcinoma syndrome without a liver metastasis? I think the answer is yes. If you have a tumor and go to the lymph node in the mesentery or in the retroperitoneum, can bypass the portal vein, so the liver cannot clear those hormones, you can have symptoms without liver metastasis. And this is very important for the female patient. I did a study, and we did a study together. When the female patient with a liver, without liver metastasis, with ovarian metastasis, so ovarian blood return bypass the liver clearance. So you're producing all serotonin from the ovary go back to your systemic circulation, bypass the liver, you are not protected. And as much as he and me try to write a paper to tell patient with female patient go through the carcinoid debulking, we should also consider to remove the ovary at the same time. This is all the questions we have here. Thank you, everyone.